Well, thank you for inviting me in part of this Congress and part of this symposium. We have done strabismus surgery for about 170 years, and we're very good at it. But there are still times when you would like to straighten an eye and you wouldn't want to operate for one or another reason. And injection has a place for that purpose. I'm going to talk mostly about a new technique rather than the standard Botox, which we have all such familiarity with. There are four kinds of medications which have been used. Alcohol historically damages the nerve or doesn't do anything at all, and therefore is a unsatisfactory treatment. Botulinum toxin has its value. I injected collagenase in a number of patients to reduce scar tissue, and indeed that was beginning to be effective. I probably gave it up too soon, and there's room for us to pick that up again. It is being used in Dupuytren contracture of the hand, and therefore the drug is available. When you do surgery, you typically change the length or the tension or the vector of the muscle, but you don't do anything to its size or strength or stiffness. Whereas some of these drug treatments, especially bupivacaine, increases the size of the muscle about 7%, increases its strength and increases its stiffness, doing something intrinsically different than surgery. 2 hours after a muscle is injected, the sarcomeres are torn apart by enzymatic action, and you are left with a bag, as it were, of non-contracting muscle fibers. Everything else is there. The blood vessels are all right, and so on. But the muscle has to be reconstructed, which it does in about 7 to 10 days. Here is a muscle 5 days, a human muscle 5 days, and you can see that there is macrophage absorption of the damaged muscle fibers and also some rebuilding of the muscle fibers already at 5 days. This is an animal experiment which shows that bupivacaine, the local drug that you use so widely and have for a very long time, when injected into muscles, has more than an anesthetic effect. It creates damage to the fibers. There is then regeneration, and then there is hypertrophy. This is the normal side. This is a growing animal, so it's slightly enlarging. But there is hypertrophy, and we see that it is persistent, that it lasts a long time. Here is a human. This is the lateral rectus muscle before injection, and here it is 33 days later, obviously enlarged. The volume increase is very modest. It's only 7 or 8%, but the muscle takes a different shape. Whereas before the muscle had its main enlargement here, that enlarged area is moved posteriorly, probably implying that the orbital fibers are preferentially involved and increased, since that is their location in the muscle. So here is that patient that we showed, 14 ESO before injection. Here she is immediately after, and of course it's an anesthetic, so she cannot abduct. A little minor hemorrhage, unfortunately, but nothing serious. By day 16, the muscle is regenerating, and she's 8 ESO here. By day 33, when I showed you that enlarged muscle, she is down to 4 ESO. And here she is 5 years later. Her eye is 6 ET still. So we see that this has an effect, and we see that it is persistent. The second of our cases had a imaging chemical, gadolinium, added to the injection. We see that it surrounds a little bit the lateral rectus here, and her 10 ESO has been corrected, and it is stable for 4 years. And here is the third case we injected, pre-injection 25 ESO, corrected some of it. At 161 days, he was re-injected, and then later on, he was 4 or 8 or 10 ESO, an adequate correction for his cosmetic strabismus. But here he is 3.5 years later, and he is still 8 ESO. All of this to show you that this is persistent and lasting, an effect quite different from what we are used to seeing in Botox. The injections that I have done have had, utilizing these concentrations of bupivacaine, a little bit more than what you have available for anesthetic use. About 12 prism diopters correction average. In this paper, Dr. Woodefan, utilizing 0.5%, got 9 prism diopters correction, and very importantly in her paper, the deviation was the same at day 1, 3, at month 1, 3, 6, and 12. That is to say, it did not diminish or fall apart. If we are going to make muscles stronger, when is a good time to use this? Well, convergence insufficiency would be a good time. We could do something to make the medial rectus muscles larger and stronger, and indeed, that is what happened for that series. If you take this muscle then and you destroy it, so to speak, it is going to rebuild itself. But it's going to rebuild itself in the region, in the way that the muscle is held. So if you hold the muscle and make it shorter, it rebuilds itself to a shorter muscle in a period of 3 weeks or so. If you stretch it out, it will be a longer muscle, and therefore we can manipulate the length of the muscle. So if we inject a little bit of Botox in this gentleman who has a residual continuing exotropia with a limitation of adduction here, immediately after injection, of course, there is a limitation of adduction because we've limited the medial rectus muscle, and a few days later we begin to see that the Botox in the lateral rectus has limited that movement. So instead of the lateral rectus, the medial rectus being able to be stretched out, the lateral rectus is paralyzed partly for about a week, about a month, perhaps, depending on the dose. And therefore, here he is at this time with 16 ESO, and at 33 days he's ESO, but here he is now corrected because the medial rectus has been able to contract and regain its strength. Here he is 2.5 years later, and if we have cases with very large deviations, it's also possible to put a little bit of Botox in the lateral rectus, some bupivacaine into the medial rectus. So here he is after 55 days, reduced in deviation to 30, but now re-injected. And you see the injection has markedly increased the size. This is just a few minutes later, 20 minutes after injection. of 3 ml of relatively concentrated bupivacaine. And here he is 224 days later, and let's look, and 2.5 years too. It's also possible to take an eye like this one, which is a very large eye, 32 millimeters in diameter. Can't correct it really with Botox, but with bupivacaine and Botox together, this muscle enlarges and holds the eye inward, and here he is years later. So in comitant horizontal strabismus, bupivacaine or bupivacaine and Botox together, if the deviation warrants it, will correct about 70% of the deviation in this very first series that has been done. We're actually a little better than we were at the beginning, so we could expect those numbers to, if anything, increase. Unfortunately, bupivacaine does not work in palsied atrophic muscles and make them bigger and stronger, which is something we would very much like to have happen, but it doesn't do it. It does work in a partially paralyzed muscle, and that makes it possible to think, if I got a lateral rectus palsy, and it started now to continue after 5 or 6 months, maybe it's a good idea to put some bupivacaine in there and keep that muscle bulked up so that when it recovers, it will still have some activity. So it does work in partial sixth nerve, it does work in partial third nerve, and we have not tried it yet in fourth nerve. Here's a girl that has a third nerve palsy with some aberrant regeneration. Oops. See if we can move ahead here. She was operated on and made esotropic. Unfortunately, however, when she looks up, the eye goes down, and after we lifted her brow a little bit, we put Botox in her superior rectus to make it stronger, and in the levator to make it stronger. And I'm going through these much too fast. And she winds up with an eye which is acceptably straight. She can actually fuse at that position. When she looks up, the eye no longer looks down and does not pull inward because it has been changed. The muscles have been physically changed. You're all familiar with large myopic eyes that become esotropic because the lateral rectus muscle slides down, the superior rectus muscle slides over, typically requiring surgical treatment. However, here's a lady whose esotropia, and here she is before. Her esotropia is corrected by injection of Botox in the medial rectus to relax it, and bupivacaine to enlarge and increase the lateral rectus. And 54 days later, she's quite straight. She can adduct fully. This is not an effect of the medial rectus still being paralyzed by Botox. And she can abduct. And days later, months later, her eye is still straight. Look at the size of this muscle now. It's an enlarged lateral rectus muscle. It's a stiff lateral rectus muscle. It's a different muscle than the muscle you would just do a recess resect on, and it holds the eye out there in a steady position. Sorry about this. It's hard to correct this. This is useful in a couple of other instances. In blepharospasm, there's inability to open the eye often, even though Botox and surgery and levator shortening has been done. So if we could make this levator muscle a bigger, stiffer muscle, it wouldn't pull down so much. And Botox or bupivacaine injection into the muscle makes it a muscle which is now more effective. You can see this right eye, which was the more closed ptotic eye, is now the more open eye. And the other eye was done a bit later, and it is also open. Here's a sequence of this in another woman. We see the eye which can barely make it above the pupil. After bupivacaine, there's slight damage to this muscle and some swelling, but then we see that her eye is progressively opening, and at the end of a month, her eye is more open than the other eye. So this is an interesting treatment. This is something that will actually probably replace a lot of Botox injection, and something that presages our ability to actually take muscles and change them and move them in interesting mechanical ways, quite different from just tightening them or loosening them or moving them over the globe as we do in surgical treatment. Thanks so much.